Good morning, everybody. Welcome to Cardiology Grand Rounds. We're delighted again to continue our series of Pioneers in Cardiology lectures with our special guest speaker, Dr. Nannette Wenger. Again, we want to really thank the Daniel and Hetty Whitebook and Family Foundation for their support for this series. Which has really allowed us to bring world-class cardiologists, leaders, and pioneers to the University of Miami to discuss their innovative ideas and careers and interact with the fellows. It's really been a tremendous program that I know our fellows have enjoyed, and for the most part, I think all of our pioneers have enjoyed as well. So with no further ado, I'll call up Laura to introduce Dr. Wenger.
Good morning, everybody. I am pleased and honored to introduce Dr. Nannette Wenger. She's the professor of medicine in the Division of Cardiology at the Emory University School of Medicine. She's also a consultant to the Emory Heart and Vascular Center, and she's a founding consultant to the Emory Women's Heart Center. She received her medical degree from Harvard Medical School in 1954 as one of the first female graduates, followed by training at Mount Sinai Hospital, where she was the first female chief resident. She's also among the first physicians to focus on heart disease in women with an expertise in cardiac rehabilitation and geriatric medicine. She has received numerous awards over the course of her career, including the Distinguished Achievement Award from the Scientific Councils of the AHA and its Women in Cardiology Mentoring Award, the James D. Bruce Memorial Award of the American College of Physicians, the Gold Heart Award, the highest award of the AHA, a Lifetime Achievement Award in 2009, and the inaugural Bernadine Healy Leadership in Women's Cardiovascular Disease Distinguished Award from the American College of Cardiology. She chaired the U.S. National Heart, Lung, and Blood Institute Conference on Cardiovascular Health and Disease in Women, is past president of the Society of Geriatric Cardiology, and is past chair of the Board of Directors of the Society of Women's Health Research. She also chaired the World Health Organization Expert Committee on Rehabilitation after Cardiovascular Disease, and she also co-chaired the Guideline Panel on Cardiac Rehabilitation for the U.S. Agency for Healthcare Policy and Research. Dr. Wenger serves on the editorial boards of numerous professional journals and is sought-after lecturer for issues related to heart disease in women, heart disease in the elderly, cardiac rehabilitation, coronary prevention, and contemporary cardiac care. Again, we are very honored to have you, and may you.
Good morning, and thank you, Laura, for that introduction. It sounds almost like an obituary, but I must admit I'm quite alive. What I want to do is to spend a little bit of time talking about specific aspects of cardiovascular disease in women. I'll address, as you can see from the title, the epidemiology, the importance of awareness, issues of access, and something that has really risen to the forefront in clinical medicine these years, the delivery of equitable health care. What I'll do for each of the areas is to give you the background information and then cite the gaps in knowledge. And for any of you who are looking for research projects, that's a list you can check, and it's a sizable list. And then suggest to all of us a call to action. Let's,
your mouse, use the mouse.
or you'll have to show me this does not work as promised. Oh, you.
I think it's, you can press
This
here.
one? Okay, very good. Okay, these are my disclosures. And as background, as all of us know, cardiovascular disease remains the leading cause of mortality, both for women and men in this country. But what we've seen over the years is that our research data showed major biologic differences between women and men in their responses to social, environmental, and behavioral stresses. But as you've heard in many sessions, the underrepresentation of women in all of the research studies delayed the translation of some of these discoveries to women. But if you take but one message away from my talk this morning, it is this. We need, as we talk to our colleagues and as we talk to our patients, a cultural shift in the way we present cardiovascular health data. Because what we do is we identify the characteristics in men as an implicit gold standard, and the presentations in women are termed atypical. They're atypical compared with the men, but they're typical for women. And I think you will see this not just in cardiology, but in many other areas. And obviously what I will do is to highlight the gaps in knowledge that we see. Now, traditional cardiovascular risk factors, the things that we learn, are highly prevalent in women in this country. But there are very important racial and ethnic differences, important as we see a culturally diverse population of patients in our clinics and on our wards. Hypertension highest in non-Hispanic Black women. LDL is highest in non-Hispanic white women. Diabetes is highest in Hispanic women. And if you look at all of the data in the charts that are presented, the Hispanic cohort is mostly Mexican American and may not be representative of all of the Hispanic patients that you see. That is not, it's a language designation. It's not a genetic designation. And I think we have to drill down on that. Overweight and obesity highest in non-Hispanic Black and Hispanic women. Now, the prevalence of the traditional risk factors is similar for women and for men. But both women and men in this country, sadly, and you see it as you see your patients coming into hospital and in the clinic, have suboptimal control of hypertension, of diabetes, and dyslipidemia. And that's contributing to the epidemic of cardiovascular disease and the rising cardiovascular mortality that we're seeing. But smoking and hypertension are the first and second risk factors responsible for years of life lost. These are remediable. That's really the challenge. Now, what we have are specific, sex-specific risk factors for women. And that's a long list. Early menarche, premature menopause, polycystic ovary disease, hypothalamic amenorrhea, hypertensive disorders of pregnancy, and I will be coming back to pregnancy issues, gestational diabetes, preterm delivery, either a low or a high birth weight fetus, oral contraceptive use, and menopausal hormone therapy. So there are a lot, and look at the list. None of these are in the standard risk scores that you use for risk stratification. And what we've seen over the last few years, and that is responsible for a great deal of the increase in maternal mortality that we're seeing in the US, is that we see lowered cardiovascular health in pre-gestational and pregnant women. More women are coming to pregnancy with poor cardiovascular health, and that increases the risk of adverse pregnancy outcomes. And also, as they develop complications of pregnancy, it lowers the cardiovascular health of their children. And we're now beginning to accumulate a sizable database of the fact that the woman who has a preeclamptic pregnancy, that her children are at higher cardiovascular risk. So we're now telling the pediatricians it's important to get a maternal OB history to identify risk factors in children. Now, in addition to the sex-specific risk factors, there's sex-predominant risk factors. Systemic inflammation, autoimmune disorders, more common in women than in men. And your woman patient with lupus will not die from her lupus. She'll die from a cardiovascular complication. And because of this, at the Emory Women's Heart Center, what we have is we have a cardiologist in the rheumatology clinic, meeting the women where they are and identifying the cardiovascular issues. So it's not a separate appointment for the women, but they begin to get the identification and the rheumatologist just send them next door to the cardiologist. Depression and anxiety more frequent in women, particularly at younger age. And as we learned from the Virgo trial, depression and anxiety specific risks for myocardial infarction in young adults, more so for women than for men. And then obviously sex predominant risk factor are the cancer chemotherapies, especially the chemotherapy for breast cancer. And you know, it's so sad when I see a patient in clinic and I say, you know, congratulations, your breast cancer is cured. You now have heart failure. And what we have to do is find a way of mitigating the adverse effects of these cancer chemotherapies. Then we have to talk about population attributable risk factors, because that's, if we're going to do public health interventions, and this has now become a public health problem, we have to identify the population attributable risk so we can prioritize our approach to public health. For white women, obesity and hypertension are the greatest risk factors for the development of heart failure, which is increasing incrementally. Black women, what we've seen is a temporal increase in diabetes as a risk factor for heart failure. It was years ago, it was not as prominent as it is today. And for Black women, hypertension and diabetes put them at most risk for the development of heart failure. Now, what I want to do is just to go through a list of some of the issues that are going to be important in terms of cardiovascular disease in women, and some of the things that those of us who take care of women patients, half of our population, must be aware of. First is the fact that nearly half of the women in this country have cardiovascular disease, if we include hypertension as a cardiovascular disease. So 1 in 2 women you'll see will have some form of cardiovascular disease, and higher prevalence of coronary disease, heart failure, and stroke in non-Hispanic Black women. Now we see different disease patterns. Women have more ischemia with non-obstructive coronary disease and increased myocardial infarction with non-obstructive coronary disease. That is to say, when you see ischemic heart disease for women, in addition to the standard obstructive disease of the epicardial coronary arteries, that's the characteristic pattern for men, you're going to see microvascular disease and vasospasm. And this is probably one of the most active areas of research today, because we don't really know how precisely to identify it, although now we're beginning to get some non-invasive means. We don't know how to treat it. And this may be why when you see a patient who has coronary revascularization for an acute coronary syndrome, more women than men will have residual angina, because they may have obstructive disease of their epicardial coronary arteries. They may also have microvascular disease that we've not treated with that stent. Women have an excess of spontaneous coronary dissection. And the people who live in the cath lab know that when you see a young woman with an acute coronary syndrome with very few risk factors, look at every one of those arteries to make sure that there's not a spontaneous coronary dissection. And I don't think it's occurring more frequently. I think we're looking for it now and finding it. Stroke prevalence is comparable for both women and for men, but women who have a stroke have higher mortality and have higher disability. And we'll talk about some of the temporal issues and access to care that may explain that. And you know, we used to think of peripheral arterial disease as a disease of men who smoke. Fact of the matter is more women have peripheral arterial disease than men, significant morbidity and mortality, and in every one of the studies, they are treated less with evidence-based therapies. But what we're seeing, and what you see as a result on your wards and in your clinics, is we've seen a decline in mortality, but it's decelerating in the past 4 years. And actually what we're seeing is an increase in mortality from heart failure. And I think remember, we're treating so many acute diseases, but if we don't treat them properly, if we don't treat them continuously, we're going to see the end stage of heart failure, and we're going to see mortality from heart failure. We just had some data reported out from the SPRINT trial. You know, everyone was very interested in SPRINT. We're treating to lower targets. Patients did much better. It was a 2-year follow-up on SPRINT. And at 2 years, there was no difference in blood pressures. So the ones who had the intensive therapy that was not kept up to 2 years. Is it a patient issue? Is it a system issue? Is it a physician issue? I think it's all of the above. Now, what about risk prediction? That's what we do. When you do a cardiology consultation, you're asked to do a risk assessment. I think our surgical colleagues say, I want you to clear this patient for surgery. We don't clear anybody for anything. What we do is we define what the estimated risk is. And as you all know from your practice, our anesthesiology colleagues are very risk averse. So they want us to define risk and to say, is there anything we can do preoperatively to lessen that risk? Well, what do we do with our CRI? We look at age and sex and race and cholesterol and LDL and blood pressure and antihypertensive therapy, diabetes and smoking. But that's only part of the picture. Look at the other risk attributes that I listed for you. And then when we look at primary prevention, the primary prevention was derived predominantly from cohorts of middle-aged white men. How applicable is it to the diverse racial and ethnic patients that we're seeing? And the social determinants of health, which have come to the forefront really with the COVID pandemic, are not captured at all in any of this. And I've listed for you all the pregnancy-related factors on the chronic inflammatory disease. And then what we see in our guidelines, the most recent cholesterol guidelines, they define risk enhancers for women. And it's most of that list that I gave you. But what a risk enhancer suggests is that these probably matter less. Well, they're probably much more important for women than some of the traditional risk factors. And my message essentially is we're going to have to do better with risk scores, because the risk scores, while they are better than nothing, are still not good enough. Now, prevention interventions are grounded in a healthy lifestyle. And over the years, clinicians have not done much to address lifestyle issues in that precious 10 or 15-minute visit with the patient. And one of my mentors, Dr. William Cannell of the Framingham Heart Study, made a very interesting comment. He said, physicians in this valuable visit are hesitant to tell their patients what their mother-in-law would have told them for free. Well, I think what we have to do is we have to get into that mother-in-law role in our clinic visits, because lifestyle is important. And we all learned Life Simple 7. Well, the Heart Association has made it a little bit more complicated. It's now Life's Essential 8. In addition to the smoking and BMI and physical activity and DASH diet and cholesterol and blood pressure and fasting glucose, sleep is now in the pattern. And rather robust data that less than 7 hours or much more than 9 hours of sleep nightly is also a risk factor. So too little or too much. So that for those of you who are on call 3 nights a week, that's a risk factor. When you oversleep on the weekend and catch up, that's also a risk factor. Now, what we're tending to see is that cardiovascular health is poor in the young women, in the 20 to 44-year-old women, and particularly during pregnancy. If you take 2 cohorts of young women, pregnant and non-pregnant, during pregnancy, the cardiovascular health by all of these indices is lower. So should we be surprised that we're seeing an increase in maternal mortality? Cardiovascular health in our challenged populations, non-Hispanic, Black, and Mexican women. And gestational hypertension increases cardiovascular risk, even if it subsides after pregnancy. And then something that we've not addressed as much. As we looked at some of the data and as we looked at COVID data, there are increased disparities with rurality. Patients living in rural America have poorer general health outcomes than do those in the urban cities, and maternal mortality is highest in the rural areas. Again, we'll talk about what contributes to that in a few minutes. So then, as we do prevention, we have to look at the intersectionality of some of the things that I addressed with you. And one of the headlines was that more women met their physical activity goal in 2018 than 20 years ago. It's just 20%. So 1 in 5 women meets a physical activity goal, and nearly half of the women don't meet their aerobic activity or muscle strengthening guidelines. So we're becoming a nation of sedentary people, more so for the women than the men. And this is part of the genesis of the epidemic of obesity and diabetes and resultant cardiovascular adverse outcomes. And one of the things that we saw as we began to look at some of these determinants is that there is a very strong association of income with meeting physical activity guidelines. But income is probably one of the major contributors to the social determinants of health. And social determinants of health, very important for physical activity guidelines. If you can't go outside of your home safely to exercise, you have to hear that from your patients so that you can give them alternate places to exercise. And what we found in our Atlanta community is we do better with our senior citizens because they're now senior centers in the impoverished neighborhoods, and they can go there and exercise safely where they can't safely walk outside their home. Okay, knowledge gaps and research needs. So anyone who wants to study, here are some of them. We have to change our risk calculators so that we have the sex-specific and sex-predominant risk factors. And we need some cross-disciplinary research in the social determinants of health so that if we do this, we can design the appropriate interventions to address these determinants. When I talked to the cardiology group last evening, I highlighted that the Joint Commission that accredits hospitals now requires that the electronic medical record include the social determinants of health. So you're going to have, now, as I said last night, the challenge is in the implementation, whether or not they're going to require a specific area in the electronic medical record that is SDOH, or whether you're going to have to hunt all through it to get them. But it's going to be one of the items on the Joint Commission for Accreditation. So I think an advance, but an advance if it's implemented properly. And then what we have to realize is that if we're going to do prevention, we can't, it's a public health issue. We can't do it solely in the office. We need communities, we need health systems, we need business, we need urban developments, we need economic researchers. This is one of the very exciting areas where we can do very much interspecialty research. And then we have to adopt those risk interventions that embrace this intersectionality and cultural sensitivity. And remember that risk management is a lifetime issue. We used to say, well, let's look at risk factors at age 35 or 40 or 45. We're seeing patients with myocardial infarction and stroke before that. So obviously we have to change our guidelines so that we capture them to avoid these adverse outcomes. Now let's talk a little bit about the awareness of cardiovascular disease in women. Because if women and their providers are not aware, then the preventive interventions will not happen. If you don't perceive risk, prevention doesn't rise to the front. And what happened is about 2004, the educational and advocacy campaign started in the US, from the National Heart, Lung, and Blood Institute, from the Heart Association. And it increased the awareness that cardiovascular disease was a problem for women. But the awareness increased from 30 to 56%. half of the women we did better, but half of the women was still unaware. And then the same study was done just pre-pandemic. And there was a 74% decrease in awareness among women that cardiovascular disease was their leading cause of death. And the awareness was the least in the highest risk population, the younger women, the Hispanic, and the non-Hispanic Black women. So this tells us where our message has to go. And in this 2019 survey, fewer women recognized common heart attack warning signs. And that recognition was less among younger women. And the Virgo study showed us that the young women come later to emergency care. And we've all learned that time is muscle. Now, it's not just the patients, it's us. We health professionals, all the health professionals have to be aware of the risk factors in women and the course of cardiovascular disease in women. And yet, when we queried, 70% of the postgraduate medical trainees reported that they received no or minimal sex-based medical concepts. That was not part of the educational curriculum. And 22%, only 1 in 5 of primary care physicians and fewer than half of the cardiologists felt that they were well prepared to assess cardiovascular risk in women. Now, obviously, this is an educational need. And what we need is collaboration between the OBGYN clinicians and the cardiologists, because there's a general lack of awareness of pregnancy-related cardiovascular risk, and that is not identifying women, because now we're beginning to see the follow-up studies on preeclampsia shows that the adverse cardiovascular outcomes begin in the next 2 to 5 years, while women are still in their reproductive years. So what's happened is we've lost a decade of progress. And we have to find a way to target younger audiences. And the conventional ways that we've done it are not working. And what we need is to partner with people who know social media, who know the areas where young people access information. And this is where we have to do our prevention. And the Heart Association has this Research Goes Red registry, where they're querying women in the community and trying to get these messages out. So what we have to do is get specific approaches to remedy the decline in awareness. And they have to be culturally sensitive for race and language and ethnic groups. And we have to do professional education, ongoing lifelong learning about specific intrinsic and extrinsic risk factors, so that we can appropriately treat women who are at risk for cardiovascular disease. Now let's talk about the access to and delivery of equitable health care. And as we did some of this examination, and it's not the literature that I traditionally read, but I learned a lot as we prepared this manuscript. Access to affordable insurance and out-of-pocket costs obviously affect access to healthcare and use for women. But 1/4 of women in our country spend $2,000 or more on medical costs each year. That's cash. And more than 1/3 report skipping medical care due to costs. The Patient Protection and Affordable Care Act, Obamacare, was probably the greatest benefit for women because it was the largest coverage increase for women in the 19 to 64-year-old age group. And in 2018, which is the last year pre-pandemic that we had good data, the percentage of uninsured women was 31% lower than it was previously. But it's still high, it's still 10%. And I just think back to the State of the Union address the other night and how often healthcare became an item that the politicians are addressing. And it's not just preserving Social Security and Medicare, it's access to Medicaid. So we're going to see this on the political scene. And I think we're going to have to become very politically aware to ensure that care of our patients. And as I suggested, that the medical expansion in the ACA had a major beneficial effect on healthcare coverage and use in low-income women of reproductive age. And you know, those of us in Georgia are not terribly proud of our healthcare coverage, but we did something very important because a number of us went down to the Gold Dome and testified before the committees. And now in Georgia, Medicaid will cover women for a full year after delivery. Previously, it was just 6 weeks. Now women are being covered by Medicaid for a full year. So we have the opportunity to address the problems that were identified during a complicated pregnancy. Remember, I said there are problems with rurality. The women in rural America have a higher cardiovascular risk, and it's lesser access than healthcare system delivery. So, and we saw this in COVID. I don't even have to display it for you. But what we've seen is that over time, the difference in life expectancy between rural and urban populations has increased. It used to be about half a year. Now it's more than 2 years difference in life expectancy if you live in rural America. And there's so many things. It's hospital care, it's outpatient care, it's clinician supply, it's insurance covered, it's a public health infrastructure. They all differ in rural America. And I think for those of us who live in big cities, we don't realize that if you go to the rural communities, you've got a third world country in many areas. Now, a higher percentage of women than men delay prescription and dental care because of costs, uniform in every study. And you know that if you delay care, the diagnosis is less, preventive care is less. And obviously with this, there'll be more adverse outcomes when an acute cardiovascular event occurs. And despite the fact that women have a lower prevalence of MI, acute coronary syndrome, there are disparities in treatment, in care, and in mortality. And after coronary interventions, women continue to have increased mortality. After coronary bypass surgery, women continue to have greater mortality than men. Some of it may be access to care. Some of it may be that we're looking only at macrovascular disease and not looking at microvascular. But there is a persistent increase in mortality for women. Now, again, as I said before, women are probably almost 2 to 3 times more likely when they have an acute coronary event to have non-obstructive disease. And we don't know how to treat non-obstructive disease. We're treating it with essentially the same medications, the same approach that we treat obstructive disease of the epicardial coronary arteries. That may not be the right thing. And obviously mortality higher in women than men, particularly at young age, as we saw from the Virgo trial. But one of the interesting things that we found in looking through the reporting from the databases is that when there is an ACS, women under age 65 have lower rates of the optimal daughter balloon time of 90 minutes. No treatment gap for women over 65. So the perception of our emergency room colleagues is that if you're an old lady, you can have an infarct. But if you're a young woman, you shouldn't be having an infarct, and I'm not going to pay acute attention to it. And fewer younger women get the 10-minute ECG when they come in with complaints of chest pain. And then what is it that we do differently? When you have identical clinical history, and this was done in a computer study, and say, who would you send for cardiac catheterization? The identical history, but different demography. Women and Black patients, same history, less likely to be referred for cardiac cath. Not just in the coronary arena, what about heart failure? In the Get With the Guidelines registry, there were no major differences between women and men. But the women were more likely to be treated in the hospital that had a higher proportion of the dual eligibility Medicare, Medicaid. And those are the hospitals that traditionally have poor outcomes with everything. Data from the Joint Commission. And with heart failure, women are less likely to receive an ICD. Same ejection fraction. Is it the women's decision? Is it the strength of the recommendation? Is it the education? We don't know. It's probably a combination. And then when you use mechanically assisted circulatory support, no matter what it is, LVAD or any of the others, women have higher mortality. Some of that was device size, because the devices and the access were larger and were not appropriately sized for the women. And the same increase in mortality was seen in smaller bodied men. But now we have smaller devices and smaller access. The women still have increased mortality, and we don't know why. And then what about the stroke registry? Remember, I told you about the stroke data and said I'd come back with some numbers. Women with a stroke are less likely to be transported to the hospital by EMS, less likely to receive imaging within 25 minutes, and less likely to receive lytic therapy within 2 hours. So should we be surprised when women are more likely to die within 30 days of the hospitalization? We're not doing that prompt early access that has basically revolutionized stroke care. And you have a very intensive stroke area here at the hospital. Look to see, are there differences in the outcomes between the women and the men? And interestingly, for those of you who are looking for research and don't want to write a big research grant, if you look at what happens in your hospital and you're looking at a quality assessment, the hospital will support that without a formal research grant. And many of our trainees do quality assessment of care at the hospital, and the support comes from the hospital because they must report quality metrics. So what are the knowledge gaps? What are the research? How do we work with women to overcome the cost barriers that cause them to delay care and less prescription drugs? And what we need is a change in healthcare policy. You and I are not going to do this in the office. And how can we improve the knowledge gap and education of healthcare professionals of female-specific and predominant risk factors? The COVID epidemic, I think, made everyone aware of differences. But what we saw is that there was a disproportionate negative effect on women because of increased economic, social, and family demands on women during the pandemic. And we've seen that specifically in our medical arena with all of the medical professionals. And then what we have to do, because time is really very important, we found, in the women's access to care. How do we improve the timing? How do we see that women will get to see 2 providers on one visit rather than coming one day for the x-ray, the next day for the provider, etc.? If we can start grouping visits and tests, we're going to have better access to care. Now, the other feature in the research arena that I feel very strongly about is that because there are small numbers of studies with women, and of the small numbers of women, there's small numbers of women in underrepresented groups, what we have to do is uniform and harmonize our terminology so that if we use the same terminology, then we can group the studies and we can use the AI parameters to get some data for the underrepresented groups. But what we have to agree on is what we're talking about and what we name it. And I think we're going to understand a lot more using the AI parameters to define the factors that regulate cardiovascular risk in women. And I've talked about the expanded use of the social determinants of health. But there's one other thing that I'm hoping that we will do. Typically, when we do an intervention, what do? We look back to capture longitudinal data trends. But now, if we're changing, I think we have to incorporate a look forward mechanism and sample trends as we do it. Because if we're not getting what we think we should be getting, then we have to change our approach. And we've not gotten the methodology down to sample as we go. So, number of things that are my call to action for all of us. Culturally sensitive with appropriate translation awareness campaigns so that women learn that cardiovascular disease is their major health threat, and emphasizing prevention because 80 to 90% of cardiovascular disease is preventable. And I think we don't address that enough and then emphasize the benefits of lifetime cardiovascular health optimization. But we need an interdisciplinary group. We have to work with the vascular neurologists, the primary care folks, and the OBGYNs, because this is where the women get their care. We need holistic risk-reducing strategies. And then, as I've said, we need better risk calculators. And then we have to advocate the basic translation of clinical and population research. And we have to focus on the under-resourced populations. As I said to the group last evening, we have to be sure that the basic science people know the provenance of their cells and tissues. Because over the years, we saw that research on women's problems was done on male tissues and male animals. No one ever challenged that precept. Now that is part of NIH mandate from the Government Accounting Office, that they have to know the provenance of their cells and tissues. And then we have to augment the recruitment of women in clinical trials. We're doing better with middle-aged women, but the older women are not being recruited into trials and the younger women are not being recruited into trials. And these are the populations. At the Emory Clinic, we've started posting little poster boards, which says, ask your provider about clinical trial. You may be eligible for a clinical trial. We're just giving it to the patients. And amazingly, some of them will say, what's a clinical trial? And are there clinical trials? And the NIH does have a website of trials in the areas where they're being done. And then this is going to become a community problem. We need communities to optimize cardiovascular health. We need school-based programs so that we teach about health in the school. And if the children learn it, that information will go home. And then we have to meet our underrepresented groups in the community where they are and partner with communities of faith. You've all seen the study of the barbershops, that those barbershops where Black men went for their hair care. When there was a pharmacist, there was a tremendous improvement in hypertension control and adherence to antihypertensive medications, meeting the people where they were. Why aren't we seeing it for the women in the nail salons and in the hairdressers? That's not yet happened. And I think that's one of the areas that would, for the people who are interested in community health, that's where we need to go. And then we need to get the people in our School of Public Health to realize that they have to be involved in primary care. It's not an abstract area. And then what do we do as citizens of our community? Advocating public policy and legislative focus on social determinants of health. Where can our patients have access to healthy food, safe spaces for physical activity, clean indoor and outdoor and air, and access to high quality care for prevention and treatment? Now this, and again, my base of operations is Grady Hospital, which is just a stone's throw from the Gold Dome of our legislature. And we're down there very, very often, because this is one of the ways we think we can improve the care for our patients. We need surveillance systems, and we have to see how well we're doing so that the stakeholders will realize that. And then what we've not done is to leverage innovative digital technology, because we don't still have good metrics for prevention, outcomes, and care. And I think the picture says it all. If we are to reduce the risks and burdens of cardiovascular disease in women, We have to raise awareness. We have to optimize prevention and clinical care. We have to support research, basic clinical translational. We have to engage communities. We have to advocate, and then we have to monitor progress to see how we're doing. And I thank you for your attention. Questions, comments? Come now, you see these patients all day long.
So I'll start off as usual. That was a great presentation. Both presentations really very thought-provoking and make us think a lot about these issues. So a few years ago, I wrote an editorial with Al Buxton about personalized medicine versus guideline-based medicine. There's a natural tension between the lumpers and the splitters, right? You want to, when you look at aggregate data for populations and when you split it up by type, which is exactly what you're talking about. So, I mean, obviously you want to make the best decisions for individual patients, and you highlighted a lot of groups where we don't do that because we aggregate. So how do you strike the balance when we've set the bar of, randomized clinical trials to make decisions? Are we going to do we need to do randomized clinical trials separately in men, in women, by ethnicity, by racial groups, or when can we aggregate the data?
Remember, these are called guidelines. They are not engraved in stone. They are not the tablets that came down at Mount Sinai. So they are designed to guide care. And if you read the introduction to the guidelines, and I've been in so many guideline committees and I've had to read that to my committee every time, but they're being used for the wrong purpose. The insurers are using guidelines to say what they'll pay for and what they won't pay for. They're being used for quality metrics. Now, for those of you who worked at the VA, for a while, the VA computer system, when they had the ideal interventions at discharge, would say, if not, why not? And that allowed you to do the individualization. And I think this is what we need. We need a guideline, and we need something that says, if not, why not? And then some of the approach is to talk to patients as to what they expect from their care. And we don't do that. And many patients, and particularly older and sicker patients, will say what they want is improved mobility, fewer hospitalizations, and a medication regimen they can afford and adhere to. And they are not interested in that many of the details. And if you know what your patient wants, then you can frame your recommendation to what the patient wants. And I think that we are going, to me, this is what personalized medicine is. And for a while, what we did in pre-COVID in our Grady clinic, and I think we're going to start doing it again, is we had a little Post-it note that was given to the patients, and it says, do you need a refill on the medications? And check it so the patients wouldn't forget as they talked to the physician and the refills got done. And then, what do you want from this clinic visit? And that starts the conversation. And I think that's a very simple way to do this within the 15 to 30 minutes that were allotted for a visit. And it becomes very important when you encounter a new patient. Because if you know what the patient expects from the disease, then you're going to be able to frame your recommendations for testing and for therapy accordingly. And if the patient's wishes are unrealistic, you can begin to address those. And if they want too little, you may say, why don't you want this and this? But that's where the conversation should be.
Great. Go ahead.
Thank you so much for your time. For this wonderful talk. I was wondering if you could talk a little more about how we should be working with OBGYN to try to target this population of younger women and what else might need to happen from a public health perspective.
Again, I think that you have to try to see if you might have a rotation, for example, in the postpartum clinic for the preeclampsia patients. Everyone has that. So you'll see what's going on there and you'll see what is the best way to tie them into your primary care or internal medicine or cardiology. And as I said, we have a cardiologist in that clinic. The whole area of cardio-obstetrics is becoming a subspecialty, and it has resulted in some very interesting interventions. First place, U.S. Preventive Services Task Force is coming out with a new statement, and it's now open for public comment on the control of blood pressure during pregnancy. Elegant study done in pregnant women, finding that tighter control improved outcomes. So we're now doing much tighter control of blood pressure in pregnancy, which was never the case. ACOG signed on to it. And it also showed us you can do a trial in pregnant women. And when I looked at the paper, I said, I don't know any of these people. I don't recognize the names except one. A good hypertension specialist from UAB was there, but I didn't know any of them. They were all OB people who did that trial. And because it was done by their people, it was adopted. We now identify the high risk for preeclampsia, and the women get low dose aspirin throughout their pregnancy. Is it going to make a difference? I hope so.
We'll see.
But you have to see them antepartum to be able to institute this. But we're beginning to do something as we get data to work with. But I think you really have to meet with the OB people, see the patients that they see, and probably, I don't know how much Miami has community clinics or whether everything is done at the mothership. But if there are community clinics, these are the doctors that you have to work with. And these are the people who see those patients and refer them in.
All right, so we have a question from the chat. They'd love to hear your tips for advocacy and influencing policymakers.
I think as an N of one, you don't do anything. And I've worked with the professional organizations. I've worked with the advocacy group of the American College of Cardiology, the American Heart Association. Your hospital always has an advocacy group. So get your priorities to the advocacy group and spend your time. I really hesitate to count the number of hours I've spent in Georgia and going to Washington, D.C., but I think it was worth it. I think it was worth it. And there are specific congressional caucuses that we worked with. And early on with the heart disease in women, we worked with the Women's Congressional Caucus in the Senate and in the House. And these were women who were particularly interested in this, and they were some of them who put some of these bills forward. So I think, you know, as I said last night, there are 4 steps: investigate, get the research, educate, teach patients and us, advocate, and then legislate. And for some of the things, we're going to have to legislate.
Carlos.
Thank you, Dr. Wenger, and I'm sure our fellows are looking forward to sit down with you this afternoon and pick your brain a little bit further. My question is one of the points you brought up is education. You know, and in medical education, many of the things that we were taught for decades and continue to teach our fellows create a certain bias. For example, the Diamond-Forster plots that we've all seen. For any stage, typical angina, atypical angina, and non-anginal chest pain, women have a lower risk, of having pretest probability of coronary disease. And so how do we reimagine that in these new calculators, risk calculators? Because we understand that microvascular disease, may be the presentation. And we talked about, calling those studies false positives, but we know that how do we recreate new risk scores, and educate our students?
First, look at the new chest pain guideline that Dr. Galati chaired and realize that they said the word atypical should be out of our discussion. And we shouldn't, I don't ever want to see it in a note, because it may be typical for that patient. So we're talking about cardiac chest pain, possible cardiac and non-cardiac. And remember, let's not beat on our colleagues in the emergency room. Most of the chest pain that they see is not serious. It's the small percent. And the question is, when there's so much background noise, how do you get the signal out? And the answer is listening to the patient. But the fact is that chest pain for anybody, EKG within 10 minutes, and then the follow-up. And that 10-minute EKG has saved lives.
Okay.
Very inspiring the point about the cardio obstetrics, it's more than obvious. Women's heart clinics. How would you structure such a clinic? Like what specialty would bring in? Where would you locate this clinic? How would you do that?
I don't understand your question.
How would you structure a women's heart clinic? And ideally, in an ideal situation.
Well, again, no, I think you start with the Life Simple 7 and realize that most of it is lifestyle, and spend a fair bit of time on this. Now, this is where I found that our APPs are really, really good, because they will spend more time with the patient. They'll give them the access to resources, etc. And what we did actually just a couple of days ago for Heart Month at Grady is we produced a video that said, what does the hospital, this was designed for employees who have cardiovascular problems. What is it that the hospital will do? And we define the exercise. We have a food as medicine program. We define the psychosocial resources. We define the exercise. We define the screening programs that the hospital has. But by defining what the hospital has to offer, we identify the problems. So if you identify the potential interventions, then you can identify where the problems.
Okay, so we have still a busy morning for you with our fellows, research presentations, and your noontime presentations. So at this point, we really again like to thank you for joining us here at the University of Miami, and also to celebrate your illustrious career for over six decades. Really a major contributor to cardiovascular medicine. And, on behalf of the Division of Cardiovascular Medicine, I'd like to present you with the Pioneers in Cardiology Award.
Wonderful, wonderful,
And
wonderful.
thank you so much for joining us.
I believe was her.
Don't see your face.